Okay, well, with that, I hope we can move straight on to Professor Sonali-Sethi. So, Sonali, looking forward to your talk.
Thank you, Dr. Singh. Do you mind allowing me to share my screen? Okay, there we go. And am I in presenter view?
Yes, you are.
Okay, great. Thank you so much. So I want to start by saying good morning or good afternoon or good evening, depending on where you are in the country. And thank you once again for taking your time out on the weekend to join us for this discussion that we're having today. So I'm going to talk to you today about the clinical value of bringing single-use bronchoscopy into the bronchoscopy suite. So most of us are probably already using disposable scopes in our ICUs. However, the majority of us are probably not at the point where we're actually using these in our bronch suite. In full disclosure, I'm not quite there either. We're not using these in our bronch suite currently. However, after putting this talk together and doing a literature search, I've convinced myself that it's very much food for thought and I need to start thinking about changing my own clinical practice. And the hope from my talk is that you'll feel the same way at the end of this discussion. So my objectives today are to review the FDA guidelines with you, get a better understanding of where these are coming from and why bronchoscopy and what exactly are bronchoscopy associated infections. We're going to go through some of the most important papers that I think are out there with regards to infections. We're also going to discuss why reprocessing our reusable bronchoscopes is such an issue. What do we require of single-use bronchoscopes if we want to bring them into our bronch suite? What is the environmental impact of all of this? I know a lot of us are very environmentally conscious at this point. And finally, what my own conclusions and thoughts are after going through all the literature. So since 2015, the FDA has issued multiple safety communications on infections associated with reprocessed flexible bronchoscopes. They, in fact, started an ongoing comprehensive investigation into infections associated with reprocessed reusable medical devices. And they started working with federal partners and manufacturers and other stakeholders to better understand the critical factors that are contributing to device-associated patient infection and how to best mitigate it. This is actually called the MOD report. It is out there. It is accessible to everyone to see. In recent years, because of this, the FDA actually started posting safety communications and warning letters related to reusable flexible bronchoscopes that potentially compromise patient safety. So where is all of this coming from and what do we know? What we know today is that reusable flexible bronchoscopes pose a risk of nosocomial infection transmission between patients with the identification of human proteins, DNA, and pathogenic organisms on fully reprocessed scopes, despite us doing full adherence to guidelines. So I'm going to go over why that might be and what we have actually found in the literature. So contaminated scopes have been linked to numerous cases of infections and pseudo-infections. We all know what an infection is, but what is a pseudo-infection? A pseudo-infection is isolation of infectious organisms and specimens due to colonization or contamination of the bronchoscope. So between 2015 and 2022, there were 867 medical device reports which were submitted with actually 7 deaths related to infections and reusable flexible scopes. The most frequently reported organisms you can see here were Mycobacterium, Pseudomonas, Serratia, and Klebsiella. Even when the FDA reports the true incidence of infection related to bronchoscopy is most likely underreported. And why is that? So a lot of this is fault from our own. So symptoms from an infection may be masked by the patient's underlying condition. So you don't actually realize that this is an actual infection that you're dealing with. As a bronchoscopist, you may not actually know all the microbial isolates that are in your facility to recognize an unusual pattern. So you may not be picking up on the pattern of what's going on when an infection is recurring again and again. Microbial contaminants very easily get labeled as a colonizer by a lot of us. And of course, there's always the fear of legal repercussions that we each have. So this is a first paper that I want to highlight. There's three main papers in the literature that I want to go to. And this was a paper that was titled The Pseudo Outbreak of Adenovirus in a Bronchoscopy Suite. So this academic center found a cluster of adenovirus in bronchoalveolar lavage samples. All bronchoscopies were inpatient bronchoscopies, and they were actually performed in a single bronchoscopy suite. They found that 10 patients had a positive adenovirus PCR, and 8 out of 10 patients had bronchoscopies done with one of two bronchoscopes. One was labeled scope A and the other was labeled scope B. Of a total of 11 patients who had a bronchoscopy with scope A and had adenovirus testing, you can see here that 6 or 55% of them had molecular evidence of an adenovirus infection. Of a total of 24 patients who had a bronchoscopy with scope B and had adenovirus testing, 17% of these ones were positive. And they did note in this paper that the reprocessing area, because they went and looked at this, did not yield any deficiencies that they could see. So the conclusion of this paper showed that bronchoscopy-related pseudo outbreaks are occurring despite standardized procedures for high-level disinfection that are occurring in our own suites. Of a total of 35 patients, 30% tested positive for adenovirus, and that's a very significant number. 30% of these patients tested positive. This was a second paper that was published in Chest in 2019 by one of my partners actually here at the Cleveland Clinic, Dr. Mehta. And the title of this paper was Bronchoscope-Related Superbug Infections. The aim of this study was to investigate the risk of bronchoscopes transmitting infections of carbapenem-resistant enterobacteria and multi-drug-resistant organisms. So in this study, they did a PubMed search and found 12 reported cases of bronchoscopes transmitting carbapenem-resistant enterobacteria or multi-drug-resistant organisms. They excluded any cases that involved rigid bronchoscopes or other type of microorganisms such as mycobacteria and fungi. And what they found was that 10 out of 12 reports stated that the scopes had been reprocessed according to guidelines. So again, they were stating that their reprocessing guidelines were appropriate. The conclusion of this study was that reusable bronchoscopes may pose an under-recognized risk for transmission of carbapenem-resistant enterobacteria and other multi-drug-resistant organisms. And even when high-level disinfection guidelines are followed, this process actually may not be effective. They additionally noted that damaged reusable bronchoscopes increase the risk of this transmission. So the last paper that I think that's very important to highlight was also published in Chest. This is probably the most highly cited paper with regards to infection that was recently published out there. And this study was done to evaluate the effectiveness of real-world bronchoscope reprocessing methods using a systematic approach. So this was a prospective observational study that was done in 3 large multi-specialty hospitals in the US. What they did was they examined 24 clinically used bronchoscopes. 9 of them were therapeutic, 9 were pediatric, and they had 6 EBUS scopes. And they actually had 2 newly acquired therapeutic bronchoscopes that had not been actually used or reprocessed as of yet. And they went ahead and measured levels of protein, ATP, and infectious organisms both before and after manual cleaning and high-level disinfection of their scopes. They had microbial culture samples, which were harvested from ports and distal ends using sterile swabs. These were moistened with sterile deionized water. It was placed into transport medium. This was done the same at all 3 centers. Channel effluent was actually obtained using a flush brush flush technique, and channel swabs and effluent were then placed in a neutralizing broth. Proteins were actually detected in samples from 100% of bronchoscopes after manual cleaning. I want to say that again. It was detected in 100% of these scopes. Microbial growth was found in 14 fully reprocessed bronchoscopes, so 55% of manually cleaned scopes and 58% of the high-level disinfected clean scopes. At 2 of the sites you can see in this graph on the right-hand side, the reprocessing was inadequate as a result of multiple episodes of non-compliance with guidelines. So I'm sure that's happening actually in a lot of our institutions. We all try our best, However, even in the third site, which you can see here, which is site A, where the reprocessing met national guidelines, there was still an unacceptable high level of bioburden that was found on these scopes. So what they found in these scopes is that they observed irregularities on 100% of clinically used bronchoscopes. And they identified things like cracks, as you can see here with this EVA scope. There was fluid, there was discoloration, there were scratches, there was filamentous debris, there were dented channels that were seen. These were more pictures that they're posted of examples of debris that were found and dented channels that were seen within all these scopes. So the results of this paper showed that bronchoscopes had visible residue and debris. There was a high contamination at all sites. Reprocessing practices actually vary from institution to institution. Damaged bronchoscopes were in use at all of these sites, which is probably happening at all of our sites as well, and storage conditions were insufficient. So what does that mean for those of us that are in the bronch suite? Contamination is occurring more often than we think, and quality improvements need to be made now. So we can no longer, after looking at these papers, sit aside and ignore these issues. We actually need to start addressing them. Because of that, and Dr. Singh mentioned this before, the FDA released this statement on June 25th, 2021, that said you need to consider using single-use bronchoscopes in situations where there is an increased risk of spreading infection or when there is no support for immediate reprocessing of the bronchoscope. So this includes multi-drug resistant organisms, immunocompromised patients, patients with prion disease. Of course, everything changed with COVID-19. So when we're treating patients with COVID-19, and so again, the time to start thinking about switching to single-use bronchoscopes in our suites in these situations is now. So what is it about our reprocessing of our reusable scopes that is such an issue? So as we know, bronchoscopes are in contact with mucous membranes, and we don't enter sterile tissues or the vasculature with the actual scope. So devices in this category warrant a high-level disinfection. When a bronchoscope is used for a procedure that breaches the mucosa, it is then recommended that the accessory that breaches the mucosa is either single-use or undergoes sterilization. That's why most of the tools that we use in the suite now, or on the floors or wherever we go, are disposable things that we're doing. So these are your EBIS needles, your forceps, your brushes, even your cryoprobes. Now everything has essentially gone to disposable. So what is going on with reprocessing of our scopes? I actually did not realize how complicated this process was until I spent a day with one of our reprocessing technicians who went through this step by step with me. And I'm not going to go through this. It's a very, very complicated process. And these are all the key elements that are actually need to occur in reprocessing our scopes. I actually didn't know that staff need to wear like full-on PPE. And that means they need to have on masks, gloves, they need to be gowned. If PPE is not used, then the staff are at an increased risk of infection and they can recontaminate fully processed scopes. Mechanical cleaning needs to be performed as soon as the procedure is finished. And then you need to obviously go on to your leak testing. You need to assess the integrity of the scope coupled with brushing and flushing. And then the scope undergoes high-level disinfection. The reprocessing area itself needs to be near where the bronchoscopies are taking place. You don't want to be walking through the hospital with dirty scopes from one location to another. So the soiled scope should be brought to the reprocessing area immediately after pre-cleaning in the procedure area in order to avoid contaminants drying on that outer surface and the internal channel of the scope. And the reprocessing area has to be separate and have proper temperature control and ventilation. This actually is our reprocessing center here at the Cleveland Clinic, and there has to be a separate entrance for your dirty scope, and you actually have to exit a separate entrance with a clean scope. So as you can see here, this is us walking into our reprocessing area. You enter with your clean scopes first. The pre-cleaning takes place first. You then get to, in your leak testing, you then get to your high-level disinfection. Clean scopes then need to exit from a separate exit and then get hung appropriately within closets with space between scopes. So for high-level disinfection, this can be a manual process, or you can utilize an automated endoscopic reprocessor. It's actually recommended that it be an automated endoscopic reprocessor. You can only use disinfectant solution, which is approved, and the scope has to be loaded in the machine appropriately. And after cleaning, like I said, the scope has to be stored in a hanging position in a cabinet with appropriate aeration and with adequate space between the scopes to prevent cross-contamination. So even after doing all of this, let's say we do all of this appropriate, we have the proper setup, how are all these scopes getting contaminated? So as I showed you, there are damaged scopes. I showed you a lot of examples of this. There's actually inadequate manual pre-cleaning. There's contaminant reprocessing equipment. There's disinfectant failure. That means there's not enough chemical concentration. There's not enough dwelling time that's happening with these scopes to soak. There's recontamination that can occur after disinfection, and then there's inappropriate storage. So you can see here that there's many steps at which point your scopes that we currently are reusing can get infected and cause trouble in our suites. So if you're starting to think now that, okay, I need to start thinking about using reusable scopes in my suite, what are the things that are important to us about single-use bronchoscopes and bringing them into our suite? So obviously their clinical performance is very important. This is just a very short list. Obviously, many companies are working on high-quality reusable scopes. They all understand that this is the future of bronchoscopy. Dr. Singh showed you a slide of that. This is a very limited list of current bronchoscopes that are available. These were only some of the pictures I can find. That, you know, this did not include Storts or Access or Cogentix or some of the other ones, that there's a lot out there. And as you can see from some of these pictures, there have been design changes that are going on with the scope. So some of the companies are making working channels that are designed differently to possibly allow for better suction. Companies definitely want the scope to hold and feel like your reusable scope. You want it to actually feel like it has the same exact quality as the current scopes that you're using. The swivel designs are very important. We've all gotten very used to using those swivel designs. Companies have been very cognizant of that. So they're working on next generation scopes to get it as close as possible to that feel and quality of what your current scopes are doing in the suite. So what are the desired attributes you would want to have of these scopes? So I thought about this and I kind of made up a list. So for me, to use these scopes in my suite, I would want them to be versatile, meaning that they can be used in a wide array of diagnostic and therapeutic procedures. We don't have a lot of scopes yet that can be used in certain diagnostic procedures like EBUS scopes. However, a lot of the scopes that are out there could be used in other diagnostic things. It could be used in peripheral lung nodule work. It could be used in a therapeutic arena within central airways. So some of it is there, but some of it still needs to be worked on. You need to be able to easily maneuver the scope. You want to be able to get into certain subsegments. You want to be able to swivel the scope. You want to make sure that the angulation is right. You want to be able to do tube rotation. It needs to be both convenient and efficient so that you're getting the job done with just that scope. Image quality, this was already brought up in the past. The image quality needs to be equivalent to what we currently have. We need to be able to visually have a good three-dimensional aspect of what it is we're doing in these airways, and we need to be able to store those images. We need them to be able to communicate with the current software programs that we're using now to type up our bronchoscopy notes and to store all our images. And we want a portfolio variety, meaning that there are many different sizes of scopes that I can use depending on what it is that I need to be able to do. So there are a couple of papers that have started to look at these attributes with single-use scopes. So this was one that was a little more recent, and this was a prospective observational study. And the purpose of this study was to assess the quality of the A-scope 4 based on 300 bronchoscopies in 21 Spanish hospitals. So bronchoscopists actually, after going through this and filling out their questionnaires and whatnot, highlighted its portability, the immediacy of use, and the possibility of taking and storing images. Overall, the A4 scope scored well for ease of use and imaging and aspiration. There's an A-scope 5, which is about to be launched that you are all aware of, and that should have even more enhanced attributes. In addition to this paper in the literature, there are many other operator perception studies that are starting to come out. This is another study that was looking at the WABIP scope compared to current reusable scopes. And they found that the single-use scope had the advantage of better maneuverability and actually better suction when they had both attendings and fellows rate these scopes. What about the environmental impact? We are all very environmentally conscious of these scopes, and it's a lot of plastic that we have in our hands. And what are we doing with these scopes after we're using them? This was one study I was able to find actually in environmental impact. This was a comparative study on environmental impacts of reusable and single-use bronchoscopes. And what they wanted to do was compare CO2 equivalent emissions and energy consumption from a single-use scope and a reusable scope. They found that reusable scopes have a comparable or higher material and energy consumption, as well as higher emissions of CO2 equivalents. Therefore, single-use scopes are safer for the environment, is the conclusion of this paper. I also know in speaking to some of the companies, I did try to see and look online to see what recycling programs are currently available, and companies are actually actively working on recycling programs for the scopes so that we're not just throwing them away. So everyone is environmentally conscious of these things, and hopefully these programs will all be put into place very soon in all of our hospitals. So in conclusion, this is the list of the advantages that I find of single-use bronchoscopes over reusable bronchoscopes and moving towards them in my own bronch suite. And I hope that you're agreeable with this list that I was able to come up with when I thought about this. So some of the advantages of single-use scopes, obviously, is I went through the whole reprocessing. I went through all the steps that could possibly go wrong. I went through papers that showed that we're not all very good at doing it, despite the fact that we want to be good at doing it. And even when we are reprocessing scopes adequately, we're still having a lot of issues with our scopes. So single-use scopes don't require any reprocessing. So we take care of that issue that we are currently noticing going on. We've gone over some of the infection papers that I hope convinced you that there are advantages in certain patient populations. I work at a huge lung transplant center. Infection is very important in these immunocompromised patients. So lung transplantation is definitely one place where I think, me doing my BAL and my surveillance transbronchial biopsies with a flexible scope that's reusable, that's a single use, is probably better than a reusable scope where I could possibly be cross-contaminating patients and not realizing I'm doing it because we're masking a lot of this or writing it off as that is part of the infectious process of these patients, or it's a colonization. So other immunocompromised patients that we may have, those patients obviously with prion disease, not something I see often, but definitely something I learned that needs to happen. And in fact, if you use a reusable scope in a patient that has a prion disease, the recommendation is that scope has to be completely taken out of commission and thrown away, or the same scope has to get used in that same patient again and again, but cannot be used in any other patient. What about those patients that are at risk of spreading disease or virulent germs such as TB or hepatitis? I think this is a great place that a single-use scope needs to happen in our bronch suite. And then I was thinking, what about I train a lot of fellows in bronchoscopy training in my cadaver labs. This is a perfect place. Why should I be using the reusable scopes in those cases? Other things that I was trying to think about how this could be useful is they could potentially, single-use scopes could potentially decrease delays between procedures when you're waiting for scopes to get cleaned. So for instance, we only have a certain number of hybrid scopes, and sometimes you're waiting, another room used the hybrid scope, you're waiting for it to get cleaned, you want it for a peripheral case. If I had a reusable, if I had a single-use scope that was the same size, I could use that instead. And this could potentially allow me to increase the number of bronchoscopies that are performed in my suite. How about the end of the day, when you're asking everybody to stay because you have a late case that's going on and a scope needs to be cleaned, and the reprocessing staff need to stay as well. So it could be used at the end of the day, so the staff aren't required to stay, and they could go home at a decent hour. And what about the off hours? So when I'm on call and I have to come in the middle of the night or on the weekends, it's difficult for me to get the scopes cleaned. At that point, I don't have my normal staff here and I have to send it out. So I do the initial pre-clean, but then there's probably hours that are taking place before that scope is actually getting cleaned. And this may be where using a single-use scope would be a much better situation. So having said that, I'd like to thank you, and I would welcome any questions that you may have at the end of the presentation.
Fabulous. Thank you, Sonali. That was an absolutely fantastic walkthrough. Really appreciate it. And I know there'll be questions and discussion around those interesting points later on. So